Good evening. My name is Eddie. I'm pleased to introduce our comprehensive pain management plan. There are two clinical practice guidelines that we will be investigating. One is the 2012 Canadian Guidelines for the Diagnosis and Management of Fibromyalgia, and the second is a 2006 Guideline for Adult Insomnia. I'd like to introduce our case, Susan. She's a 42-year-old female from a small northern community called Fort St. James. While working as a care aide, she had injured her back about 3 years ago, and in combination with her diagnosis of fibromyalgia, she was unable to work. She's currently on long-term disability. She was healthy until about her 30s, and then about 8 years ago, she was diagnosed with irritable bowel syndrome. About 5 years ago, while working, she'd injured her left rotator cuff, and the MRI was inconclusive, but it resulted in her being unable to work for about a month. And again, 3 years ago, she'd injured her back, which kind of was a catalyst to her being off work for this time period. She's the oldest of 3 children. She was the primary caregiver of her mom, who suffered from chronic pain as well and died recently. She feels a bit burnt out. She's always cared for others, and so the death hit her really hard. Her father was in the logging industry, and he died about 10 years ago. They described their relationship as it was a complicated relationship. She's been married for about 10 years. She's got 2 children, a 9-year-old daughter, a 7-year-old son. Her husband works at a local sawmill. And as a result of her not being able to work, they've been experiencing some financial challenges. They've been having some marital problems as a result. Her husband is the sole earner. He is supportive, but the reduced intimacy, he's finding it challenging. She feels isolated. She doesn't really have any activities that she likes to do, and she really struggles to keep up with home life. She's friendly with mothers, but she doesn't really have any close friends, and one of the reasons is she is fearful of activity. She's scared of increasing her pain. On good days, she tends to do household chores and has difficulty stopping. It's just because she feels she needs to get them done, and long sitting and standing she does find uncomfortable and painful. Her mother-in-law lives in the same community. She comes over regularly and helps often. She organizes dinner. She does things with her grandchildren. The kids are generally okay. They are able to get themselves ready for school. They can make their own lunches, but usually after school, that's when they overwhelm Susan. They have some emotional demands, such as when kids are fighting. And even though she feels the most important her accomplishment is raising her children, she does feel a bit of a loss of control, and she wishes that she could have more quality time. She no longer sees her family physician. She often forgets appointments, or she was billed for missed appointments that weren't canceled. The doc didn't understand her, and so she went and found another family doctor. From a spiritual side, she did used to go to the Baptist church, but actually stopped after her father died. She does enjoy playing the guitar and walking, and she has recently been referred to the Vancouver Chronic Pain Management Center.
It has become evident that Susan's care, which was followed a biomedical model in her community of Fort St. James, has been ineffective in helping her manage her ongoing pain. Susan has now been referred and accepted to the Chronic Pain Self-Management Clinic in Vancouver. This program follows a biopsychosocial model with involvement from a team of professionals, including an anesthetist, psychologist, social worker, occupational therapist, physiotherapist, nurse, and recreation specialist. The FM Guidelines 8 and 13 recommend this approach as the ideal, as it incorporates the principles of self-management using a multimodal focus. During week 1 of the program, Susan met with all clinicians individually. She also completed a series of questionnaires, including the Survey of Pain Attitudes, the Beck Depression Inventory, the Pain Catastrophizing Scale, and the Fibromyalgia Impact Questionnaire. Although the FM guidelines recommend the Perceived Global Impression of Change questionnaire, we felt that the questionnaire selected would provide a much broader construct of the factors that affect Susan, such as depression, anxiety, function, fear, etc. Now to highlight the focus of the assessment and findings from the various disciplines. The physician on the team completed a medical history and physical, while the nurse assessed Susan's understanding of pain, her medical diagnosis, her rehab focus, whether she was open to change or continued to seek a cure for her ongoing pain. She also had Susan complete a medication diary for the first week of the program, which would give insight into Susan's intake pattern. Other health issues were also assessed. The findings from this assessment indicated that Susan had little understanding of chronic pain, her medical diagnosis of fibromyalgia, and she had significant fears around doing further harm when her pain escalated. She was also very fearful of taking medications, as she had never taken medications in the past, but she was afraid to stop them as her pain always escalated when she did try to reduce her medications. It was also identified that Susan had a history of IBS, which was impacted by her poor dietary pattern and her high caffeine intake. She had a non-restorative sleep pattern, which is a commonly associated finding in FM patients. She had difficulty getting to sleep and woke often during the night. As a result, she had a tendency to nap for long periods during the day. She also drank 2 to 3 cans of pop in the evening and watched TV in her bedroom at night. Although the physician determined that there were no primary sleep abnormalities such as sleep apnea, which ruled out the need for polysomnography, Susan was assessed by the insomnia nurse specialist, who had Susan complete the medical outcomes survey sleep scale to provide input into Susan's sleep problems. Susan's medications on admission included amitriptyline 10 milligrams, temazepam 30 milligrams at night, Lyrica 50 milligrams 3 times a day. However, Susan was only taking 1 a day because of the drowsiness associated with it. Celebrex 200 milligrams once a day, and she was taking probiotics for her IBS. Losec 20 milligrams once a day, and Atasol 30 PRN. She was prescribed 30 a month and usually took some days none and some days 3 or 4 tablets a day. To go on to the psychosocial assessment, which involved individual assessments with the psychologist and the social worker. During the sessions, the psychologist assessed Susan's emotional status and her coping pattern when dealing with stressful situations. The social worker focused on Susan's communication pattern within her family environment, her family interactions, financial issues, as well as how she perceived her role in her family. As social involvement also includes relationships outside the family, the social worker also questioned Susan on her connections within the community, whether she socialized with friends or if she was involved in her children's school activities. From the psychosocial side, it was evident and supported in the questionnaires that Susan completed that Susan was quite frustrated with her present life situation and perceived herself as having little control. She reported having memory problems, had trouble focusing, and was feeling quite isolated. She didn't want to socialize with friends as she was embarrassed about being off work and often took out her frustrations on her husband and children. Financial difficulties were also a major concern as they now relied only on her husband's salary. This was very depressing for Susan as she was always a very proud woman, had worked hard all her life and now felt out of control. To go on from a physical perspective, the physiotherapist assessed Susan's posture and body mechanics, strength, range of motion, and she had Susan complete a 6-minute walk test to determine Susan's walking tolerance, and also did a video of Susan's walking and sit-to-stand mechanics. The occupational therapist assessed Susan's sitting tolerances, sleep position, sleep aids, such as the type of pillow she used. He also assessed how Susan usually performed activities such as house chores and whether she paced these activities or pushed through despite increased pain. From the physical assessment, it was evident that Susan's sitting, walking, and standing tolerances were reduced. Her pain escalated and her walking mechanics deteriorated after 4.5 minutes of the 6-minute walk test. She had limited range of motion and her pain in her shoulder increased with movement. The back examination did not produce any physical signs for Susan's back pain and seemed related to a muscle strain which occurred 3 years prior. There was some weakness noted in Susan's left shoulder, which was related to an old rotator cuff injury, but on strength testing there was no increase of pain. Susan also reported that she was always pushed through activities, even though the pain escalated, because she thought it was lazy not to complete a chore when she started. To complement the physical and psychosocial assessment, the recreation specialist evaluated Susan's involvement in social and leisure activities. Susan had always loved playing the guitar, and walking was her favorite form of exercises. Now her shoulder pain interfered with her ability to play the guitar, and whenever she walked, her pain increased. This also interfered with her ability to play with her children and socialize with her friends. Following all the assessments, the team met to discuss their findings and to determine an intervention plan that would help Susan manage her pain more effectively, increase her overall function, and reduce her disability. For Susan, this translated into her specific goals. Susan's goals for the program were to improve the quality and quantity of her sleep per night and have more energy, to have better control over her pain so that she could become re-involved in family, social, and leisure activities, so that she could enjoy her time with her others and that others would enjoy spending time with her. And finally, Susan wanted to improve her physical abilities, such as resuming to play the guitar, going for walks daily, and managing her housework. She also stated that somewhere in the future she wanted to be able to contribute to the family income again, i.e. go back to work. To address these goals, the team worked collaboratively to address the physical, psychological, social, cultural, and socioeconomical issues that impacted Susan's ability to manage her pain. To begin, it was necessary to address Susan's fears around harm. The nurse reviewed all of Susan's previous investigations, tests, and went over these with her and provided a detailed explanation of pain physiology and hypersensitivity to help Susan better understand her pain issues. She reviewed Susan's medication diary with her and met with Susan and the physician to determine an appropriate medication plan. It was decided to keep amitriptyline at the present dose, to wean to temazepam over an 8-week period, and to continue with Lyrica at the prescribed dose. Susan also wishes to continue with her probiotics for her IBS. Regarding the Celebrex, Susan didn't find this effective, and it always gave her stomach upset, so she is going to wean and discontinue this, and when her stomach upset settles, she will discontinue the Losec as well. Since Susan is fearful of stopping too many medications at once, she will take her Adasol for a short period, following a scheduled one pill a day, and then wean this as other medications as other pain management strategies become effective. These other pain management strategies include both physical and psychosocial interventions. To address Susan's goals of increasing her physical activity, walking, playing the guitar, and enjoying time with her family and friends, Susan will need to increase her overall physical function in a pain-managed fashion while addressing her associated fears and emotional distress. To facilitate this, Susan was shown her walking video and explained what she needed to focus on to improve her walking mechanics and reduce stressors. She was started on a walking program based on her tolerances, using a SMART goal of walk 3 minutes, rest 1 minute, times 4 repeats daily. In combination with this, the psychologist began cognitive behavioral therapy with Susan and introduced her to relaxation techniques, which included scheduled lie-down breaks using good body mechanics that she incorporated into her daily activities. Since Susan had always pushed through activities, it was necessary to help her change her thinking from seeing power breaks as being lazy to seeing them as a smart, necessary strategy to assist her in gaining a quality of life she desperately wanted. The occupational therapist introduced the concept of pacing activities to prevent pain escalation. Susan soon realized that she could get more done by pacing activities than by pushing through and spending days in bed recovering after her pain escalated. The recreation specialist worked with Susan, showing her how to hold her guitar, support her leg while playing, and incorporating again the concept of pacing this activity. She started with 10 minutes playing 3 times per week. As her confidence in playing the guitar guitar increased, so did Susan's mood. She discussed this with the social worker and discussed how she felt and how her children enjoyed playing together, and discussed how she was going to do this when she returned home. Susan's sleep difficulties also had a significant impact on her ability to participate in daily activities due to ongoing fatigue, cognitive interference, and her overall mood. The physiotherapist worked with Susan to determine a more comfortable sleep position, using an appropriate size neck pillow to provide better neck and shoulder position and a body pillow to keep her in a good alignment. The nurse also discussed various sleep routines which would help reestablish a more normal day-night cycle, such as not sleeping after 1 p.m. in the day, reducing caffeinated beverages, especially after supper, which was reinforced by the dietitian, and developing a restful pre-bedtime routine. The social worker also worked with Susan on how to improve her communication pattern with her husband. Although a therapist specializing in cognitive behavioral therapy for insomnia was not available, the psychologist will implement cognitive behavioral therapy with Susan to help change beliefs and habits associated with improved sleep. This intervention plan is thoroughly supported by the FM guidelines and the clinical experience of our team. It is only through this collaborative practice, which incorporates the physical, psychosocial, cultural, and socioeconomical factors, that Susan will be able to address all of the factors that contribute to her ongoing pain. The follow-up aspect will also be an important component of ongoing effective pain management.
Prevention and follow-up. In prevention, I included the interventions that involve mostly Susan's and her family's participation upon her return home. I divided the prevention section into two categories. A, the prevention of pain exacerbation and measures to enhance her functional abilities, and B, the prevention of psychosocial escalation. To reduce pain and improve her function, we worked with Susan on a coping plan. That includes things like the use of heat or cold applications as needed for flare-ups, regular yoga or tai chi practice, or relaxation breaks, and also we gave her a guided imagery study to facilitate this practice at home. Next, we gave her a written outline of her exercise program and medication plan. And considering that she lives in a winter climate that doesn't make outdoor walking easy year-round, she said she would use a treadmill that they have at home, but that she hasn't been using. Also, she will continue manual lymph drainage massage as needed, as she feels that it helps her shoulders feel more comfortable and it helps her fall asleep at night. Then in our clinic, we gave her the book Say Goodnight to Insomnia, which she will read at home, 1 chapter per week over a 6-week period, as recommended by Dr. Greg Jacobs. Other insomnia resources are given to her as well, such as the website of Dr. Greg Jacobs, and here we have a link in our slideshow. Also, information on easy, quick, nutritious meals for the family is provided. Follow-up. The follow-up section includes the collaboration with or involvement of any additional healthcare professionals, and it includes reassessment. Susan's progress will be monitored with the help of interviews and outcome measures at the end of her stay at our interdisciplinary clinic and at all follow-up meetings. It includes liaison with the Fort St. James pharmacist, who checks for the effectiveness of her medications as well as for side effects. And it will also be reviewed by her physician if required by direction from our team. We will also liaise with a Vando physiotherapist who will follow up on her rotator cuff exercises as needed. One very helpful resource we found was telephone-based CBT offered for free by the Canadian Mental Health Association, the BC division. It is called the Bounce Back program, and it is designed for people with mild to moderate anxiety and depression. So those therapists will work with Susan on her goals. Follow-up visits with our clinic are set up to monitor the consistent implementation of the pain management strategies. At 4 weeks, we arranged for a telehealth follow-up, and at 12 weeks, we will come back to our clinic for 3 days for a visit. The Northern Health Connections bus can be used for low-cost transportation. For subsequent follow-ups, telehealth sessions are planned. And I want to mention here that the Fort St. James physician and other involved healthcare professionals are invited to attend all telehealth sessions to help with knowledge translation. Also, we will provide the Fort St. James Medical Clinic with a resource list of services and information. And this will hopefully not only benefit Susan, but maybe other pain patients in the region. At the 12-week follow-up visit at our clinic, we will do a medication review, and at this time we will consider duloxetine and or cannabinoids in the management of her pain. Another gait video will also be taken and evaluated at the 12-week follow-up visit by the physiotherapist. Also at the 12-week follow-up, Susan will be evaluated in regards to the possibility of returning to gainful employment in the future. If Susan has trouble reaching her goals, the Progressive Goal Attainment Program can be considered because that is offered via the telephone, and so it would be accessible to her. So this is essentially the plan. Regarding the guidelines, I just wanted to mention that the guidelines recognized the difficulties of implementing the guidelines in regards to CBT and the lack of availability of trained psychologists. The guidelines mention that telephone or internet-based programs may be available. Also, the recommendation number 36 refers to the follow-up of fibromyalgia patients and basically leaves the follow-up to the discretion of the physician and the healthcare professional. To prevent the escalation of psychosocial factors, the social worker arranged for family members to participate in chronic pain education sessions to learn about pacing and prioritizing activities. Another educational resource we provided is the book Fibromyalgia, A Story for Children. Also, general communication skills for effective communication with others, especially physicians, healthcare professionals, family members, and friends are taught to Susan. Also, including problem-solving skills and conflict resolution. A session was also held with Susan and her husband to discuss their communication pattern and to explore ways of how to improve it. To address financial issues, no or low-cost family activities in her community were identified. Susan agreed to participate in a chronic pain self-management program, and you will see the web link on the slide, as a refresher in the future when it is held close to her community. This will also provide an opportunity to connect with people with similar circumstances as hers.
Our learning goals. Number 1, learn more about the sleep and insomnia component of chronic pain and how to manage it. In this component, we were able to learn more about how to do an assessment and sleep history and how to apply a basic treatment approach for insomnia. Our second one was to learn more about the cognitive impairments in fibromyalgia and how to manage them. It was found that cognitive impairment can be caused by medications and in fibromyalgia are most consistently associated with increased pain. However, this area is understudied and there are no clear guidelines or directions as to how to assess, measure, and treat it, even though these are affected in fibromyalgia. Number 3, intention was to learn more about the differentiation of pains with different origins, so injury-related versus fibromyalgia-related. In this, it was understood that it's important to rule out red flags, identify physical signs, and get a thorough past medical history, and also a good evaluation and thorough assessment of acute injuries and any other new acute conditions. We also noted that when a patient does present with several comorbidities, different practice guidelines may apply. So, for example, with our patient Susan, with her chronic low back pain, it might be that acupuncture, TENS, and non-steroidal anti-inflammatories are helpful according to the chronic low back pain guideline, but for fibromyalgia, those same treatments do not have sufficient evidence to be recommended in the guideline. Number 4, we wanted to become more familiar with the fibromyalgia clinical practice guidelines and learn how to implement them into clinical practice. And we also wanted to understand and compare the value of 2 different clinical practice guidelines by using the AGREE tool. We used the very valuable AGREE website, which is at www.agreetrust.org. And this website allowed us to save our data in one place and has helpful hints about how to evaluate a clinical practice guideline using the tool. This helped us to understand that the fibromyalgia guideline was a very reliable and comprehensive guideline and was quite easy to use. The insomnia guideline, however, that we had chosen was difficult, and in going through the AGREE tool, it helped us to see specifically that there was a considerable weakness with a lack of information about the literature search. And in fact, we utilized a second insomnia guideline to supplement the guideline that we had chosen. We also realized that CPGs are not to be followed exactly, and that clinical judgment is a very important component of this process. We also, number 5, we wanted to share information and learn about different chronic management approaches, chronic pain management approaches and practices from other professionals in the class, and we all found that this was beneficial for the sharing of information and practice expertise. Number 6, we wanted to learn how we can improve the uptake of pain management strategies and coping skills in patients and their families. And we noticed that the fibromyalgia chronic pain guideline pardon me, is a great resource for clinicians to understand the importance of the psychological treatment of and treatment aspect of fibromyalgia. We also noted there were many excellent websites available for patients and their families. Number 7, we wanted to know how to use clinical practice guidelines to enable patients to maintain optimal function. We found that this guideline had condensed information with a lot of excellent up-to-date research, and we found also that the framework of diagnosis, management, and outcome sections provided clear direction. How is this CPG implemented in practice? So this was sort of more philosophical, where we were talking about what is the cost of services, noting that there are multiple services and professionals to ensure a comprehensive approach, which can be quite costly. Who pays for this? One of the most important elements that was not thoroughly explored with the guideline was who has the responsibility to manage the case, and the only model that we were able to create that would be able to efficiently integrate the CPG recommendations was to create a pain center. These primary clients are usually insurance company such as workers' compensation, disability claims, and motor vehicle accidents, where the burden of loss is incurred by a third party. The other aspect that we noticed was that when trying to locate appropriate health professionals in a more rural region, it was quite difficult. It was difficult to ascertain whether we could access this from a public or a private stream, and it seems obvious that when we start moving towards a more comprehensive treatment direction, smaller centers definitely do not have the resources available. We also wondered what would be the relative percentage of improvement should all the recommendations be met, so that from a financial perspective, is a 300% increase in dollar cost to provide service worth a 10 to 20% gain in function. Does the clinical practice guideline meet our requirements? A couple of recommendations were that that some of these be scaled, so in terms of critical elements and non-critical elements. So there was no indication about which of the recommendations was more important, whether they were critical, moderate, or optional. This would also enable us to address the area that could result in the largest amount of therapeutic gain. And then also there was no timelines particularly addressed in the interventions. And that's our goals. Thank you.
On behalf of my team, I'd like to thank you for watching our presentation. If you have any questions, please feel free to ask.